All right, everyone, we're going to get to 7 o'clock Eastern time right now. So I'd like to welcome everybody to today's webinar. Today is December 8th, 2020, and we really hope everybody is staying healthy during these times. In Olympic efforts to provide virtual and socially distanced educational content, today is the first of a series of 3 webinars on setting realistic expectations in the GI suite. Let's talk about the facts of conventional duodenoscope infection rates, culturing, and lab results. I do have to walk you through our legal disclaimer. I will try to talk fast yet clearly. The comparison to competition has been written to the best of our knowledge at the date of publication. Please keep in mind that our competitors enhance their products, so their products may have changed. Make sure you use your competitor comparisons carefully in your conversations with customers. This material does not constitute medical or legal advice and should not be relied upon as such. This material should not be considered as a substitute for carefully reading all applicable labeling, including the instructions for use supplied with the devices and published peer-reviewed articles concerning the topics presented. Before using or selling any product, please thoroughly review the relevant user manuals for instructions, warnings, and cautions. The techniques, instruments, and settings can vary from facility to facility, and it is in the clinician's decision and responsibility to decide in each clinical situation which mode they use. Thank you for bearing with me through that. I'm going to go ahead and introduce myself. My name is Melinda Benedict. I am currently the Global Senior Manager of Infection Prevention for the Olympic Corporation of the Americas. I concentrate on our gastroenterology and pulmonary products, and I am going to be moderating this event tonight. It is now my pleasure to introduce our 2 panelists to you that are going to be speaking this evening. First, we have Dr. Michelle Alpha. Dr. Alpha comes to us from Manitoba, Canada, where she worked for Diagnostics Manitoba for over 20 years and held the role of director for the clinical microbiology discipline. She was also a principal investigator at St. Boniface Research Center for over 25 years. Dr. Alpha is a prolific author of peer-reviewed scientific publications with over 150 works to her name. Over the past 30 years, her primary area of research has been on hospital-acquired infections, specifically related to reprocessing of complex medical devices, such as flexible endoscopes. Her research in endoscope reprocessing has highlighted the risks associated with biofilm formation, the need for monitoring manual cleaning, and the benefits of performing periodic culturing to assess microbial contamination in patient-ready endoscopes. Although Dr. Alpha is currently retired, she remains a professor in the Department of Medical Microbiology at the University of Manitoba, and I will vouch for her that she is a very busy lady. Next, we have Dr. Gregory Cote. Dr. Cote comes to us from the Medical University of South Carolina, where he is a gastroenterologist with expertise in the management of pancreabiliary disorders and related endoscopy procedures. Dr. Cote completed his schooling at Northwestern University of Chicago, where he served as chief medical resident and chief fellow before relocating to Washington University in St. Louis for advanced training in endoscopic ultrasound and ERCP. He practiced on the faculty of Indiana University for 5 years before moving into his current position at MUSC. Dr. Cote's clinical practice focuses on the diagnosis and treatment of acute and chronic pancreatitis, pancreatic malignancies, gallstone disease, and other disorders of the extrahepatic biliary tree. He is currently the principal investigator for several federally funded clinical trials in endoscopy. I'd like to thank both of our panelists and welcome them to tonight's event. So let's get started. And just to let the attendees know, this webinar is going to be mostly open dialogue between our 2 panelists, as Dr. Alpha and Dr. Cote each have a unique perspective on today's topics. If you do have questions during our discussion over the next 45 minutes, please type them into the Q&A chat box. We will attempt to get to as many questions as possible before our time is up tonight. So let's jump right in. First, I'm going to show a slide that is showing a graph based on information published by the FDA on duodenoscope MDRs related to death in respect to the total number of ERCPs performed per year. So to put this into perspective, the graphs here show all of that information. So based on a national case volume of approximately 600,000 ERCPs per year in the United States, and the incidence rate of related MDRs, the first question I have for our panelists is, what do you take from the data on this graph, and what is your perspective as far as the data relates to each other, as we can see here? And I'm going to start with Dr. Cote for this one.
Okay, well, thanks for having me, Mindy. And it's you have to take a minute here to look at the numbers, but it reflects, I think, the odyssey that we've seen over the last approximately 5 years on this issue of infection control as it pertains to duodenoscopes. And let me just start by saying as well that we'll be talking about duodenoscopes, but it's important to remember that the linear echo endoscope is very much in the same category, similar construction in terms of the challenges in the processing and keeping it clean, basically. So that's not to be minimized. But to put this into perspective, again, 600,000 or so procedures per year, and the reported number of cases are typically in the double digits per year in the worst of years, and we've seen a reduction of that in more recent years. So while it's a horrible complication and a preventable complication, it is a rare complication or adverse event from these procedures. And so it's an encumbrance on the part of providers who are offering ERCP and endoscopic ultrasound services in their facilities to do an excellent job of minimizing this issue. We need to keep in mind how uncommon it is. It was something that came up many years ago, and it was, I think, largely ignored until there were a few outbreaks of these multi-drug resistant, highly pathogenic organisms, which are really a biomarker for the problem of contaminating these scopes and then bringing them into other patients. But it was a few case series, basically, that brought this into attention. And as I see it, it turned into a very much a public awareness, sort of public relations issue for a lot of centers. And so now we fortunately are starting to see some science behind this and a better understanding of how we can manage this problem going forward. So I'll stop there.
Great. Thanks, Dr. Cote. Dr. Alpha, do you have any comments on this graph and the data that it shows?
Not much. I think Dr. Cote did a great job kind of identifying it. I mean, it's almost like our COVID outbreak, where it takes that bolus of problems initially and recognition of the problem, and then effort is put into trying to understand, what is happening, why is it happening, and how can we prevent it. And I feel the same way, that it's actually really gratifying to see that the number of deaths associated with these types of procedures has gone down, fairly dramatically over the last few years. But I think the other part of it is deaths are probably, as was indicated, it's a very harsh marker. And I think some of the other things we're going to talk about as we go forward are trying to ensure not only that there is an extremely low or no death rate associated with these procedures, but also that infections and transmission of organisms that are multi-antibiotic resistant is also on the radar as we work through these issues.
Great. Thank you both. So I think that sets the stage pretty well for some of the questions I have for you moving forward. So let's jump into the second one. And for this one, again, I'm going to start with you, Dr. Cote. What do you think the difference is between duodenoscope contamination and patient infection?
Right. Well, I'd add to that colonization, which is another important consideration here. So first let me start with the endpoint, which is patient infection. So obviously, one of the most common complications from ERCP, particularly in at-risk individuals, which for the most part are patients with complex stricturing disease in their biliary tree, those patients, in conjunction with their anatomic issue, often see a lot of antibiotics, so have colonization with resistant organisms. but also complex pathology in the pancreas when we're injecting contaminated contrast through the scope. Remembering that as soon as you place any duodenoscope, any scope into the mouth, it's a contaminated device. And so you have those factors where the procedure may cause infection as a complication. And I should mention also immunocompromised post. So for those that are patients on chemotherapy or patients who are have received organ transplantation, these are all folks that are at a relatively higher risk. And we've known that for many years. And there are technical things that can be done to minimize the risk of secondary infection, but also the use of prophylactic antibiotics. Those are the procedure-associated infections which will occur even in the best of hands. Then you have to take a step back and say, well, when is a duodenoscope causing an infection as a result of carriage of something that was picked up in one patient and delivered to the next? And Michelle can speak to this more, I think, scientifically than I can, but it's a patient who has not been exposed to a multi-drug resistant organism is the easiest example of this. A patient with a multi-drug resistant organism sees the duodenoscope, its failure to be cleaned in the reprocessing, and that duodenoscope is then brought to the next patient. That organism is then instilled in that individual, and typically in a relatively short time frame, although it can be weeks to months later, that infection can rear its ugly head into the recipient patient. But what's more common in the handling of the scopes is contamination. So the scopes are, again, our gloves is not a sterile procedure. So even when we place gloves, we take them with our bare hands out of a glove box and put them on, and we have organisms immediately on the glove. We oftentimes may touch various surfaces prior to and even while holding the endoscope. So the duodenoscope can be contaminated by all the things that we touch and even ourselves, since even with masks and so on, there's still that risk of the people that are in the room. So that's contaminated in that room. The purpose of reprocessing is to eliminate that. But what's left is, after reprocessing, if you culture the scope and you identify a bacterium, that would be considered contamination. That doesn't automatically mean that whatever that organism is, it will be carried into the next patient and infect that patient. It means that it's something that you picked up on culture. And we know that the vast majority of the organisms that are identified in culturing protocols are non-pathogenic organisms, and actually those that are most commonly considered contaminants of the process of the culturing itself. So that's I think the confusion that can arise from this.
Thank you for that. So, Dr. Alpha, do you have anything to add? I'm sure you do.
Oh yeah, there's always it's fascinating having these discussions, because I think this is one of the most pivotal misconceptions, in terms of the fact, looking at what is contamination in the scope, how does that affect patients becoming infected or colonized? And so I really liked Dr. Cote's description of it. And I think one of the key things from this is that the exogenous or the endoscope contamination that is because of inadequate reprocessing, so not during the handling, because Dr. Cote is absolutely correct, as you're going through the procedure, you are going to have organisms because of the nature of which body orifice you're going into. But I think the one thing about it is that when the endoscope is patient ready, one expects that it will not have organisms of high concern in it before it's actually handled and used in the procedure. And I think the key thing I would like to make there is that's the one part of the contamination that's preventable. Our expectation for high-level disinfection or sterilization of a fully reprocessed scope is that it would never have any gram-negative bacteria on it, and certainly not ones that were from a previous patient. So I think the focus is really to look at this logically and say, what can we do to reduce the risk that patients will be exposed to organisms that they shouldn't be exposed to? And one of them obviously is making sure that the duodenoscope or any other endoscope that is patient ready doesn't have organisms of concern in it that we wouldn't want going into that patient. And I really liked Dr. Cote's description of the transmission from the endoscope, unwanted organisms into the patient. And I think that one of the areas that I think requires clarification for a lot of people when they look at this, you know, the scope contamination that has organisms in it being transmitted is one thing, but one thing that we often talk about is how frequently does this actually happen, and does it always result in infection? And the answer to that is that just because you have organisms in an endoscope, even though they're high concern organisms, it doesn't mean that exposing or using that scope on a patient is going to result in an infection. And I like the Epstein study that was reported, and it was the CDC that actually did the workup on this, because I think it clearly shows the difference between infection versus colonization. And Dr. Cote mentioned both those terms previously. What they found was that in terms of the outbreak, when it was recognized, they realized that there were, 11 patients that actually had infection with MDM E. coli, and that raised red flags, and the CDC was called in and an investigation was done. And I think what was interesting to me is they chose to actually follow up on all the patients that those scopes had been used on and do rectal cultures to see how many people became colonized or what the transmission was to people that may have not presented with infection. And when you look at the data, 10 out of the 99 patients that the scopes were used on actually developed infection for an infection rate of about 10%. When you look at the ones that did not develop infection but had rectal swabs and they assessed the culture, they found that 27 out of 89 of those patients that were cultured actually were colonized with exactly the same strain. So the colonization data showed 30% transmission that led to colonization and 10% transmission that led to infection. And I think that's an important thing to remember is even colonization with a multi-antibiotic resistant organism is something we should be concerned with. And that's because if they have a long-term, if they are colonized with this organism asymptomatically, the duration carriage in the published literature is about 337 days. If they have an actual infection with a multi-drug resistant like an NDM E. coli, the carriage rate tends to be longer at about 640 days. So the take-home messages here are when you have organisms in an endoscope that shouldn't be there, like multi-drug resistant gram-negative organisms, this one study showed about a 10% infection rate resulting from exposure to that scope and about a 30% colonization rate that leads to carriage from that scope. Now, the recent survey that was done by the Ofsted Group 2020 did show that the attack rate can range from as low as around 6% and it can go all the way up to about 40%. So the Epstein data that I'm sharing with you is just one example of it. And of course, it depends on the type of outbreak and the patients that were exposed to it. But I think it's important to recognize there's contamination of the scope that shouldn't be there because it's fully reprocessed. And that can lead to either infection or colonization or none of the above.
Okay, great. Thank you for that. And I do want to also interject just for the attendees' knowledge. You know, as an infection preventionist from Olympus, I see that people have a hard time understanding high concern versus moderate concern versus low concern organisms. That is a topic we are going to dive into at length in the third webinar of this series. So if that's something you're interested in, please make sure to join us for that. All right, we're going to move on to the next question tonight. Please overcome them. And for that, Dr. Alpha, can we start with you?
Sure, I'll start the ball rolling. The sources of endoscope contamination, and when I talk about endoscope contamination, I'm talking more about you know, when you do culture and they identify that the scope has been fully reprocessed, but it has some contamination that's detected on culture. And so to me, the sources of that can be failure of the reprocessing, where for some reason the cleaning and the high level disinfection or sterilization didn't work, and that scope has organisms in it that actually weren't properly eradicated from patient use. So that's one source. That's a dramatic one. We hope that happens on very rare occasions. And I know that as more facilities look at their endoscopes, they will find that contamination shouldn't be anyway, affecting, 80% of your scopes that are being used in any way, shape, or form. In fact, it should actually be extremely low. So one source would be failure of the actual reprocessing. And the other one that can occur is actually the inadequate storage of endoscopes, where if there's wet storage and there's an opportunity for any organisms, whether they're environmental or from a previous patient procedure or from handling, if there's moisture in the channels, those organisms can replicate and can certainly start to form biofilm. And if this is done on a repeated one after another basis, ultimately there can be enough buildup that the disinfection doesn't work anymore. So in terms of the sources, one would be failure of reprocessing, and the other would be inadequate storage because the drying wasn't adequately done before storage. And I know that issue is one that is topical and people are paying more attention to it because it was unrecognized in the past that the AER reprocessor that has alcohol flushing and forced air drying is not adequate, and it doesn't meet the manufacturer's instructions for thorough drying before storage, and that wasn't recognized. But the published data from Bearcat and from Ofsted certainly have demonstrated that you can't rely on the AER cycle to give you adequate drying so that when you put your scope in storage, it's going to be fine. And I think with that in mind, it's important to recognize that one other source of organisms that can contaminate scopes is if the AER itself, the final water rinse, isn't adequate, you can actually have a contaminated final water rinse. And oftentimes it's water-related organisms like Pseudomonas aeruginosa, Acinetobacter, those types of gram-negatives. If your final rinse water isn't bacteria-free, and then you put that scope into storage, obviously you are basically just flushing those organisms through the channel, and that can be another source of contamination. Now, in terms of sample collection, if you're collecting a sample from a scope and you're going to do culture on it, obviously the handling of that scope can lead to accidental contamination of the sample that you're collecting, and that can be from anything. It can be respiratory secretions, if there's inadequate PPE being done when sample is being collected from the scope. You can have environmental organisms introduced, skin organisms. Those are the ones that can be accidentally introduced during sample collection. So I think that my last comment is going to be, what can you do to try to prevent that from being a problem? Obviously, handling scopes using PPE is an important parameter. It doesn't prevent it during use, as Dr. Cote mentioned. Once you start using it on the patient, that scope's going to have organisms in it, but it does prevent your skin organisms from getting on it prior to being used on the patient. Ensuring adequate drying. So if there's one thing sites can do, it's really check to see whether or not they really are getting their scopes dry enough before they put them into storage. Because if they're not, they're setting the scene for biofilm formation. And the other is, it is important sometimes to do some culturing of the scope or, look at monitoring of things, because right now quality systems require monitoring and it's changing a lot in endoscopy clinics, there's no doubt about it, but I think it is important to do some monitoring so you know what's going on. So I'll kind of stop there, but that's kind of the quote unquote microbiology kind of background in terms of where do we get contamination. So to summarize, it could be failure of the reprocessing, maybe because of buildup biofilm or inadequate final water rinse. But the other source could be the contamination or inadequate final water rinse that has organisms in it that you then are coating the endoscope with. And the The other one would be the idea that if there's inadequate manual cleaning and you're putting a scope in that has not been properly cleaned, it's more difficult for the AER to do its job properly. And then the other one is obviously during sample collection, if you're doing culture on a scope and you accidentally introduce contaminants into the scope.
Great. And I actually have two follow-up questions for you, if you don't mind. So you did mention during your talk that waterborne organisms in final rinse water can be a potential problem and a source of endoscope contamination. So do you think there is value in maybe not only sampling endoscopes, but sampling your AER rinse water?
Yeah, I think that's a great question, Mindy. To give you an example, the European guidelines actually do require a regular monitoring of the final rinse water because it is a parameter that often can go unrecognized for very long periods of time. And I myself have been involved in a couple of facilities in our province that had problems with that. And it arises because the submicron membrane filter, the 0.25 membrane filter, if it has micro breaks in it, and you may not even see a big pressure drop, but sometimes you will see a pressure drop of the water coming in, and that should be a red flag that the membrane filter may not be functioning properly. But if that happens and you get organisms on the distal side of that submicron filter, that means that the water you're getting is basically going to be not bacteria free, which is what you expect from the final rinse water. And the idea of periodically looking at that and doing culture, I think, is very important. I know in North America, that isn't a recommendation in the guidelines. It certainly is in European countries and in Australia and some other countries. The idea of checking periodically your final rinse water to make sure that it is bacteria free is important. And I do think that that is an important thing to do. But as I said, right now, it's not a requirement in the guidelines that are out there.
Great. All right. Thank you for that. Was the kind of microbiological overview of this question. So now, Dr. Cote, I'm going to go to you for the next one. So what are the procedural implications related to patient safety and infection that should be considered when introducing disposable endoscopes as opposed to conventional scopes?
Right. Well, this is a good question. There's a lot of different ways to get after this, but the first thing I'll say is, again, to go back to the original slides that we reviewed in terms of the scope of the problem is that each center needs to assess their current volumes in ERCP and endoscopic ultrasound, and really in all their endoscopy, because these issues really impact all endoscopes. It's just that duodenoscopes and linear echo endoscopes are more complex devices, and so they're more easily contaminated than the straight scopes, which have fewer nooks and crannies, basically. So that to me is an important consideration. And you have to consider the goals of the procedure. This issue of infection control aside, you want your doctor and your team to be very comfortable with the equipment that they're using on a patient. So, what I've been hearing a lot is that, for high-risk patients, you should use a disposable scope because you don't want to have that risk. And it doesn't address the endoscopic ultrasound issue. And it also doesn't address the fact that those patients oftentimes have more complex indications for their procedure. And now you're going to ask somebody who performs 90% of their procedures with a reusable scope to now take a less familiar device and ask them to do the same things. And I just don't believe that will translate into the same technical success. And so we may take a very small problem in terms of its frequency and take a more common problem of technical failure and make it even larger. And that's already a major issue with the ERCP as it stands. So that's an important consideration. I think centers need to look at their overall reprocessing sort of protocols and decide that, you need to be good at keeping your reusable devices clean. And if you decide to adopt a disposable option, it doesn't eliminate that need for all the other devices that are out there, unless you can somehow envision creating an entirely disposable platform to offer endoscopy, which at this point is significantly cost prohibitive. We haven't talked about the environmental waste associated with it and the issue of the quality of the devices themselves. So these are the things that I think about when I'm thinking about where does a disposable scope fit into my practice. And I think that decision making is going to be different depending on the type of center that you're working in. So for a center like mine, we have, and just to sort of delve into a little bit of what Michelle touched on, we have a very small number of technicians who are trained and qualified and actually perform the reprocessing of side viewing endoscopes because of the complexities associated with doing a good job with it. But we're in a center where we are using at least 4 to 5 duodenoscopes per day. So these individuals have lots of opportunity for practice, and this has become very routine. That's number one. Number two, the nurses and technicians that are in the room with us understand the importance of the bedside clean, which is not to be minimized. So it's the analogy that I've heard, which I think is a good one, is if you eat a plate of spaghetti with marinara sauce and you, when you finish your plate of food, you go to the sink and you rinse it off, and then you put it in your dishwasher, and then you run the dishwasher, an hour later, you're going to have a really nice clean plate the next day. But if you finish that plate of spaghetti and you leave it on your table, and then the next morning you throw it into the dishwasher and run the dishwasher, you're more likely to have spots on it. So the nurses and technicians that work with us in ERCP on a daily basis know that when we are finished with that scope for that procedure, they do a fairly thorough bedside clean right then and there to take really all visible biofilm junk debris that we've accumulated during that procedure. And that is a critically important first step. If you're in a center that does this once a week or once every couple of weeks, there's a greater likelihood that they're going to consider that scope to be just like the colonoscopes they use on a day in and day out basis. It's getting a little bit of feedback from someone.
Sounds like a plane taking off.
Yeah, I hear it too. I know. I don't know. Lewis, he's our tech guy. If you're on, I don't know if everybody's muted. It's definitely not coming from Michelle, Greg, or I.
Everybody is muted.
I can speak more loudly.
Okay.
But then to sort of again follow with some of Michelle's comments, pretty much everything that she was talking about are human factors, right? So it's that first step at the bedside. It's being comfortable with the equipment that you're using in the cleaning room and the reprocessing room, and then having quality equipment for storage and actually turning your scopes over on a regular basis. So, it's fairly uncommon for us to have a side view scope that isn't used every 7 days. But for other places, you may have a scope that sits there for weeks and weeks at a time. And I think the data are a bit mixed in terms of, what the import of having a scope standing in storage for several weeks, 3, 4, 5 weeks or more, but it can't be good. So, I know at our center, we're fairly keen on those uncommon situations where a duodenoscope or side viewing scope has not been used, that we will reprocess it as if it has been used after only 7 days. So these types of human factors, well-trained personnel at the bedside and in reprocessing, and having high frequency of use of your scopes, I think those components reduce the likelihood of the human factors that really drive this issue of contamination and patient infections.
Great. And I have to say, I love the spaghetti analogy. I use a very similar one with oatmeal, leaving your oatmeal bowl to sit out. And I think those sort of analogies are very important to make some of these issues more easily understood by the people that are reprocessing our scopes. All right, let's move ahead here. So right now, what the slide is showing, and Dr. Alpha, this is going to go to you, but I think what we were discussing for the last half hour or so set a really good background, gave people really good understanding of the basis of what we're talking about. And now we can start to transition more into talking about endoscope sampling and culturing. So what's on the screen now is actually a snapshot of the front cover of the current sort of, I call it the gold standard of sampling and culturing. It is a protocol developed in collaboration with the FDA, the CDC, the American Society for Microbiology, many industry experts and outside consultants to fill the gap that was needed. This came out in 2018, and it is a very comprehensive protocol walkthrough of how to sample a scope, and not only how to take a sample and what materials are needed and what the steps are, but it also, which I love, incorporates at the back instructions for laboratories to follow, so they know how to culture out an endoscope sample once it's collected by a facility. So this did come out in the beginning of 2018. And before this, there wasn't really a very comprehensive guide on how to do duodenoscope surveillance, sampling, and culturing. So Dr. Alpha, the question I have for you is, prior to this protocol coming out, how do you think what the sensitivity of this protocol is compared to maybe what people were doing
Yeah, I think that's a really good,
2018?
yeah, I think that's a great question to pose, Mindy, because kudos to the FDA, CDC, and ASM that actually collaborated on doing this, because one of the biggest problems was, if you look at the literature before 2018 and you look at the culture positivity of patient-ready scopes, whether they're duodenoscopes or other scopes, you're going to find it ranges all over the place. And many centers would be doing testing and saying they find no contamination whatsoever. Others would be having, 35% of their scopes, growing organisms that they don't want to have growing in those scopes. And part of the issue was that there was no standardized approach to, number one, sample collection, and no standardized approach to the culture methodology. And as a clinical microbiologist, there's a couple of points that came out in this that I think were really very, very germane. The sensitivity of the culture sample collection methodology is one thing. So how efficient is your sample collection protocol? Are you flushing sterile water or buffer down the instrument channel? Are you doing a flush, brush, flush protocol? So the sensitivity of the sample collection protocol is important. And if you read the details of how the culture was, or samples were being collected historically before 2018, it's all over the map. Some people just use flushing, some people use a flush brush, and the fluid that they use was, again, all over the map. It could be a culture media, it could be buffer. So that's one level where there was a huge mix of the approach taken to culture sensitivity, and there was no validated extraction efficacy protocol. This FDA one, FDA, CDC, ASM protocol, they have had the three main manufacturers validate these protocols, and it's the only one out there that has between 65% and 100% extraction efficacy. So the sample collection itself is shown by the manufacturers to do a good job of extracting the sample from the endoscope channel. And the only one that was targeted in the duodenoscope surveillance sampling and culturing protocol was the instrument channel. So biopsy port still ends. That's one thing I look for. And the other is the idea of organisms have been through high-level disinfection or sterilization, and they're stressed. And there's a phenomenon out there called viable but non-culturable, which means that inside the when organisms are stressed, they go into a mode that is viable but non-culturable. So you can collect them in your sample, but when won't grow because they're damaged. So the idea of having a neutralizer in there to inactivate trace amounts of disinfectant, but also to stimulate the is cool. And many of the protocols in the past did not do that. And the final one is the lab component of it. How do you make it most sensitive? And idea of concentrating it, like the whole sample should be cultured, not just a drop of it, which is historically what a lot of the published data was based on, because that's not a very sensitive method. So I would say that prior to 2018, when the FDA, CDC, ASM out, that there was a huge variability in the efficacy of the sample extraction from the endoscope and huge variability in the sensitivity of the culture method.
Great. Thank you for that. I think that's a really important point, because I do also hear from, people I talk to that before they implemented this new 2018 protocol that we're looking at right now, they say things like, I never got a positive culture. And I think, to your point, that speaks more for the culture method and its sensitivity than for any potential contamination that are on the scopes. Okay. So again, like I said before, we're going to dive much deeper into the sampling and culturing topic in webinars 2 and 3. But I think to kind of wrap up today's webinar and then also lead into the 2 future webinars, I'm going to start with you, Dr. Cote, to give your input on this question. What do you think are the pros and cons of implementing an endoscope sampling and culturing program?
Yeah, so I mean, on the pro side, obviously it's a quality control check on your program. It quantifies essentially the job that you're doing in terms of reprocessing your scopes. So if you can report back that X number of organisms were identified that were contaminants, and of those, Y number were deemed potentially pathogenic organisms. That's important for reference, especially, of course, in the context of a potential outbreak that could occur at your center. But it's also great feedback for your reprocessing team, for your endoscopy unit, et cetera. It also gives you an additional check on your review of your endoscopes. So it's an opportunity to be inspecting your scope for damage that might not have been detected either in room or during the routine reprocessing steps. And obviously, if you identify a contaminant, then that scope would be reprocessed, recultured, retested, and you would, in theory, prevent the duodenoscope from being introduced to a patient particularly with a pathogenic organism in it. Those are the pros. I would say that the cons, especially as a clinician, is that, and someone who, at least to some extent, maybe not to the extent that my hospital bosses would like me to, but there's a significant added cost to implementing this on a widespread basis. So in theory, every scope would have to be removed from the circulation and cultured to make sure that it is not contaminated after every reprocessing, to assure that your scope has not contaminated when it goes back into a patient. So that is clearly not a feasible option. So you do it in a selected subgroup of your duodenoscopes, which means you need to have, and linear echoendoscopes, I should say, you need to have a sufficient inventory of these scopes, so it gets at the cost for your unit per procedure that is being done. You need to have a sufficient inventory that you can pull one or more of these scopes out at a time for the culturing process, so that you can actually execute the program that you want to implement. It adds personnel resources as well, so it has to consistently engage your infection control experts, who I think should definitely be a part of this, as opposed to trying to do this purely internally within your GI endoscopy unit. And lastly, with all of that effort, it's very likely that you will identify contaminants that occurred through the reprocessing and the culturing process itself. And so the impact on preventing patient infections, which is what we're trying to do, is we're trying to prevent patient colonization and patient infection. I think remains not clearly proven in my mind. And so these are the, I think, pros and cons that have to be taken into consideration. And that's a decision making now that has to change further with the new generation of side viewing scopes that are now being brought to market, because it's really a whole new device. And we need to have a better understanding of what the contamination rate is in these new devices that are increasingly being used in endoscopy units. So those are my takes on it.
Great, thank you for that. And then Dr. Alpha, same question to you.
I'll try to be very concise. I think one of the main factors, and I use a phrase, you don't know what you don't know. Everybody who is using endoscopes and the reprocessing personnel as well, when you ask them, are you following the manufacturer's instructions for use, they believe, and they in their hearts are doing their best job to make sure they are doing that properly. But if you don't do any culture or any monitoring of any kind, you really don't know for sure what's going on inside those scope channels. It can be surprising sometimes what you can identify if you even just periodically do a culture, and that can help you rectify that problem before it becomes a persistent problem that affects a lot of different people. I think it was interesting to look at Thaker's survey, and what they found was that in terms of surveillance of microbiology culturing in the United States, there was only about 53% of 249 centers that ever did any culturing whatsoever, but there was no indication of the frequency. And I think that gets to Cote's comment about you have to be committed to doing this, because it does take time to take cultures, and you do need dedicated training for the individuals that are collecting the samples from these endoscopes. And obviously the microbiology lab that's providing you with the feedback needs to recognize too that they need to give that feedback as quickly as possible. And in perspective, Dr. Cote, in terms of results coming back, I agree with you 100%. If you're getting a gram-positive bacilli, which is most likely a bacillus that's contaminating the environment in low levels, that's not something, how I put it, spending a lot of time on. But if you get a gram stain from the microlab that says they're growing a gram-negative bacilli, that's a whole other ballpark. And then action should be, it should be viewed as a critical result that needs to be acted on. And I think it behooves us in the microbiology lab, and it behooves us as researchers that are looking into this to try to improve the turnaround time so that we can reduce the quarantine time that's required, because you are absolutely correct that this isn't something that can be done in every scope. And I think sites need to be very selective about taking realistic fight and accommodating what they can.
All right, so to wrap up, we do have a few questions that rolled in during the course of our discussion. Dr. Alpha, I think these will mostly be directed at you. The first one, I feel like you're really going to like. Does research suggest cabinets reduce risk of infection?
Does research suggest that drying cabinets reduce the risk of infection? I would say that that isn't what we have seen. What we have seen is that the use of, and when I say drying cabinet, I mean an endoscope storage cabinet that purges air through the endoscope channel so that there is ongoing and thorough drying that occurs. What the publications have shown is that it reduces the ability of microbes to replicate. So if you have no microbes in the channel and it's dry, you will get, that's a pristine scope that can be used with confidence on a patient, and it is absolutely not going to transmit any exogenous infections. if you have, low levels of environmental organisms that get into the scope and it's dry, they won't replicate either. So in my opinion, the data that's out there on endoscope drying cabinets and forced air drying cabinets through the channels is that it helps ensure that you don't get biofilm formation. Because if you start getting formation, that's when you're going to get failure of high-level disinfection, and that's where you have a potential for the scope, when it's patient-ready, to actually have surviving gram-negatives from the gut that could be transmitted to a patient. So I have not seen any clinical studies looking at if you're using drying cabinets, does that affect the infection rates? But the data that is out there quite nicely shows that if you have if you do proper drying, or you have a forced air channel drying cabinet, you will not get replication, and that means that you're not going to get biofilm formation. Whereas if you have wet channels or moist channels, you will get biofilm formation occurring in them over time.
Okay, thank you so much for that. All right, and we do have one more question here we can get to on ATP testing. So let me find that one. Okay, again, this is for you, Dr. Alpha. How reliable is ATP testing, and are there other methods that are more reliable to establish the quality of the manual cleaning process?
Well, when I look at that kind of question, when you think about it, it's again a question of you don't know what you don't know. If there's no monitoring done, you don't know that the staff have actually removed all the organic material that those scopes were exposed to during the procedure. And it's not that they aren't doing their best job. The reality is that unless you do some type of monitoring, you really don't know precisely the quality of what you're getting. And from my perspective, any monitoring that you can do to assess the manual cleaning, that puts power in the hands of the endoscope personnel so that they can catch that improper reprocessing. And it's not even necessarily due to them doing anything wrong. It might be that that scope was used for an extremely bloody procedure, or that was used for an extremely long period of time, or the patient's bowel was unprepped and there's a lot of, much more crud in there, or somebody forgot to do the bedside clean. And the reality is that that empowers the reprocessing personnel to know that they've caught a scope that they need to re-clean before they allow it to go to high-level disinfection. So when the question asks ATP monitoring versus other methods, there's organic marker rapid test strips that can be used as well, and ATP certainly can be used to monitor cleaning. And in my opinion, if you're not doing any monitoring right now, doing something periodically to monitor and empower your reprocessing personnel, I think is an important part of a quality systems approach to endoscope reprocessing. If you think about the analogy, when we take surgical instruments, the washer disinfectors are evaluated on minimally a weekly basis and preferably a daily basis to make sure the cleaning is being done. So they get cleaning monitors put in, if not daily, then at least once a week. But we don't do the same thing, or we're not yet at that level with flexible endoscopes. It's moving that way. But in answer to this question, I think that ATP and the organic strip monitoring methodologies provide tools that help show that the staff are doing the job that they believe they're doing, because no one's trying to do it wrong, but it gives them data to show that they did monitoring and at least they met the criteria for either ATP or organic monitoring. Whereas if there's no monitoring done, they have no idea, really what's going on in terms of the efficacy of the cleaning, even though they did their best job.
Michelle, if I could ask you a follow-up question to that. So to be clear, this would not be considered an equivalent to a quarantine and culturing program, correct?
Absolutely. Absolutely.
This would be a supplement to that.
You're absolutely correct. This would be assessing, because one of the steps that has been found to be the most often done wrong and human factors affect it is the manual cleaning that's done before it's put AER. So in my opinion, ATP testing and the organic marker tests is like protein, hemoglobin, carbohydrate, monitor the manual cleaning step that's done. And the objective there is to make sure that if the cleaning didn't meet some basic criteria, that it gets for level disinfection or sterilization. It's not part of the culture and quarantine component. It's a different step of the. And asking that because I think that's an important differentiation. And I would add that, in my opinion, neither the ATP and the ATP test cannot be a substitute for culture, unfortunately. It's just not sensitive enough.
Mhm.
All right. Well, that were those were the questions we got from the audience. So I think we're going to close it out. Dr. Cote, Dr. Alpha, do you have any final words before we shut down for today?
I compliment Dr. Cote on empowering his reprocessing staff and the idea that they are proud that they because it's not easy, it's very complicated, and hope that others listening to this would incorporate that approach in terms of their staff training as well, because I think that's a fantastic approach to get a really good quality job done.
Great. Dr. Cote, any final words?
Well, it's just that this whole discussion is so complex. I hope this was helpful. I learned a few things just listening. But I think, again, this whole issue needs to be kept in context, and this is all stemming from now this evolution to a disposable option. And I think, again, this is a new option. It's always good to have more options than less, but it doesn't eliminate any of the things that we talked about tonight. These are things that I think are here with us to stay. I don't think anyone envisions going to a completely disposable platform for all flexible endoscopy. And so high quality reprocessing, disinfection is going to be here to stay. And so it's important for all centers to be on top of this. The ones that I'm particularly concerned about are the ones that do lower volume procedures using these side viewing scopes, which is the majority of centers in the US. So it's a magnified issue in the United States as compared to other countries that centralize their specialized procedures more than we do. And so I think, congrats to Olympus for trying to bring some science to all of this as well.
Great. Well, thank you both. We're going to wrap up for today. And I think, Dr. Cote, to your point that this is a very complex topic, that is the reason we were having a part 2 and a part 3 to this discussion. We just couldn't fit it all into a 1-hour session. So to our attendees, please save the date for part 2 and then part 3 of the webinar. Part 2 is January 13th. Part 3 will be on February 10th, and we will do a deeper dive into these topics. Dr. Alpha, Dr. Cote, thank you so much for participating tonight and sharing your expertise with us. I think it was very valuable and kind of a unique opportunity for our attendees to hear both a research scientist that focuses on the topic of endoscope reprocessing, and then also a practicing gastroenterologist kind of bounce ideas and perspectives off of each other. So thank you so much for your participation. And then to our attendees, thank you for being here. Stay safe, and I'd like to wish everybody good night and good health. Thank you.